currently today at our different stages through the day. We are in London, and we are very happy to have you all with us this afternoon.
You're in London? Hello?
Hello.
Are you in London?
We are, yes.
Why is it called the Kampala Initiative?
Ah, I
thought you were in Kampala.
I think that's going to become be explained in just a few minutes, actually.
Okay then. All right.
It will be revealed.
Okay.
Good question.
Ravi, should we pass over to you now?
Sure, absolutely fine. Okay, so good afternoon, good morning, good evening, wherever you are. Welcome to our next webinar in the Kampala Initiative. I want to first just call out two organizations that have come together to put this together, and that's the Nigerian Women Agro-Allied Farmers Association, led by Lizzie Igbine, and Health Poverty Action, the group based in the UK. So very appreciative of these two organizations who are both members of the Kampala Initiative for coming together and putting this together. So that everyone is aware, this webinar is being recorded, and that's so that we can follow up and hopefully we can put it on YouTube. That's to be seen. You'll note that right now all the participants are muted, and that's just so that we don't get any sound disturbances. What we'll request is that we'll hold the discussion after all the speakers have had a chance to make their presentations. So we understand that you may have some clarifications or some points you want to raise. Please do enter those in the chat box into the Q&A. And if you have something that's very substantive that you do want to make sure that is not missed, also raise your hand. And you can see in your participant bar at the very bottom, likely, of your screen, you have the option of raising your hand as well. We are on Twitter, and look for us at the hashtag BeyondAid and hashtag Kampala Initiative. And as we start right now, this is East African time just after 4 p.m. That means it's just after 9 a.m. in Eastern North America. And we are at just after 6:30 p.m. in India. So covering a wide range of time, but we will end at 4:30 p.m. Central European summertime. So that's just under an hour and a half from now.
Brilliant. Thank you so much, Ravi. So we just wanted to begin our webinar by having a temperature check to see how everybody is feeling today.
Just a moment. Just want to give people a bit of background on the Kampala Initiative, and then let me hand over to you. It's quite okay? All right,
Sure.
excellent. The question already came up. Why is this a global group, but why is it calling itself the Kampala Initiative? We'll ask if you can see on one of the forthcoming slides, you'll see a website, and we'll actually enter it into the chat box as well. That will show you the home web page for the Kampala Initiative. We were launched last year in November in Kampala at a civil society workshop there. So there were some several webinars that took place in preparation for that workshop, but just giving us a framing for the discussions that we had, we decided to name it Kampala Initiative. So what are we? We are actually a democratic civil society space. It's an alliance and a community of individuals and organizations that have come together to explore, and not just explore, but also see how we can make changes in the means by which development assistance for health or health aid is actually working. Part of that is coming up with a new civil society narrative, and we've had several webinars. So those of you who participated in the past webinars will recall those discussions. Concrete areas. We'll talk a little bit more about those as well. But basically, we've got some working groups. We've got some actions at the international country levels, looking at how development assistance for health is actually being dispersed or received and then operationalized, and seeing what can we do that's more principle-based as opposed to power-based. Also focusing, you can see, is space for discussion and exploration. That's why we're here together today. Putting together these webinars and other community tools for community engagement. Just if I can take one more slide, and then we'll proceed directly into our webinar? Great. Okay. You can see on the screen, in the middle of the screen, there are 4 bullets, and those are our 4 initial topics or themes that we covered in our original discussions, looking at aid as a stabilizing force, or is it actually working to overcome the issues that generate health inequalities across the world? Then aid and its actors themselves, are they supporting or distorting national systems, processes, and health policies? The representation of civil society forms a third area in which we've continued exploration. Now, to what extent is civil society as representatives, communities, and a divergent interests having a role in the decision-making that's generally taking place between governments with sometimes multilateral institutions or private foundations coming in? And then finally, how can we move from the traditional or conventional concept of aid toward a concept of global solidarity around health inequalities and health assistance? I'll just also make a note. We talked a little bit about the kind of activities that are going on. You've seen our Twitter hashtags. If you look at Kampala Initiative, hashtag Kampala Initiative, or hashtag Beyond Aid on Twitter right now, you'll see that we have just published a report today on Watch the Gap. That's the Global Action Plan, which is a concept among many of the big health actors, the well-funded international agencies or foundations and government bilateral institutions that have come together saying that they're going to coordinate themselves better. And we've given already a critical analysis. So we encourage you to get onto Twitter, look that one up, and you can download that report. Today, as we move ahead, we're exploring the principles behind the Kampala Initiative, and we're applying that to the COVID-19 response. So we're going to be seeing what can we do in the midst of this crisis to actually take a different kind of approach and experiment with different ways of changing the power dynamics that underlie health aid. We'll talk a little bit more about future webinars. Just one last reminder, this is the first webinar in a 2-part series. So be sure to be watching out for the same time next week when we come back and we continue this discussion. And with that, can I hand over to Clemmy James from Health Poverty Action, and she will lead us into today's webinar.
Thank you. Thanks, Ravi. Just before we go into the webinar, we're just going to ask you to pop into the chat how you're feeling, just to get a sort of temperature check of the energy out there. We're aware that these are difficult times at the moment, and people are holding a lot personally and in their place of work. So I just wanted to invite you to put between 1 to 5. 1 might be quite tired and drained. 5 might be absolutely amazing. It will also give us an indication on how to hold you through this webinar. So please just pop down a number in the chat. Great, thank you. Oh, good. We've got some 4s, some 3s. Some 2.5s, that's cool. Thank you. This is really helpful just to have a sense of how everybody is.
Great. Should we move on to the next slide, if that's all right? So, yeah, before we hear from our speakers, we just wanted to do a quick introduction about what this series is really, which is exploring how to move from aid to global solidarity in a post-COVID-19 world, which probably feels a little bit far away for some of us right now. So as Ravi said, the webinar series has been put forward by Lizzie, who is the national president of the Nigerian Women Agro Farmers Association, and also Health Poverty Action, which is an international NGO which works alongside communities, health workers and activists around the world to address the root causes of poor health and poverty around worldwide. So my name's Tess. I'm a Policy and Campaigns Officer at Health Poverty Action, and I'll be co-facilitating the webinar along with my colleague Clemmy.
Hi, I'm Clemmy, and I'm campaigns communicator in the Department for Policy and Campaigns at Health Poverty Action.
Thanks, Clemmy. Okay, on to the next slide. So as has already been said, this is a two-part webinar series, which ultimately aims to start a conversation on the future of health aid in a post-COVID context. So COVID-19 presents a huge global health challenge, and one where health aid has played an important role in our response to it. But unsurprisingly, we're seeing many familiar challenges that we see with health aid generally also being recreated in this context. So as well as these challenges, the long-term picture of traditional aid is looking a bit uncertain as economies of donor countries contract, resulting in less resources for aid, and some pro-isolationist narratives emerging in many contexts as well. So it's important for us to have a strong and bold civil society voice on the future of health aid right now. But also as we rebuild and recover from COVID-19, we are presented with a really rare opportunity to reflect on how things have been done in the past and to think about how we want to improve and rebuild them as we move forward. And there has been some conversation about the need to reform health aid for the better in many spaces over the last few months, and some initiatives coming up that have started to look at this. But we felt the Kampala Initiative provided a unique and exciting perspective and space to explore this question and how we want to shape health aid for the future, and of course to build that strong, bold civil society voice. And this comes obviously with the caveat that we know health aid is only one small piece of the puzzle when it comes to addressing poor health and poverty worldwide, but it is an important one, and a conversation we felt it was important to have. So this webinar is about really exploring the challenges of health aid through the COVID-19 response, and we'll set the scene. This webinar will set the scene for the second one next week, which is where we want to really start collectively thinking through how we shape health aid moving forward and looking at some of the solutions. So this space is really about coming together and collectively exploring this issue and sharing in our own knowledge and own expertise and own experience. And because of that, that's shaped how we've decided to run these webinars. We also hope they might be the start of a more in-depth conversation beyond this space, but let's see how we get on. If we just go on to the next slide, I'll just say a little bit about what we're doing today. So today we're lucky to have three fantastic speakers who I'm really excited to hear from, and I'll introduce them properly before they speak. But as I said, this is also about hearing from you and hearing about your experience. And because of that, we're not going to be having a traditional Q&A after the speakers. Instead, we're going to be asking a couple of interactive questions to you all, and using this for engagement through the chat box, and also opening the floor to discussion and intervention from participants later down the line. And just one more slide on this. We really encourage you to engage with the interaction and discussion that's coming a bit later in this webinar. And we also encourage you to use the chat box as we go through to share ideas, to share thoughts. You can share resources, you can have discussions with one another, but just see that as an opportunity to share ideas and things as they come to mind. Because it's not always easy to intervene in webinars, so we want to make that a space where you can share. And as I said, we won't be using the Q&A function in this webinar, again, because it's not really about questions and answers. It's much more about coming together and sharing and collectively thinking through this very big question. So if we go to the next slide, I'm very happy to welcome Abu Bakar Kamara to speak as our first panelist. So Abu is from the Budget Advocacy Network in Sierra Leone. He's been working around budget and related issues for the past 10 years and has a lot of experience in using budget data for advocacy purposes to influence policy change in favour of the poor. He has extensive experience on budget processes, including health financing Sierra Leone, and is also a researcher in public financial management. So I'm going to pass over to you, Abu, and thanks so much for being here.
Yeah, thank you very much, Tess. Good afternoon to you all, and I have to talk in point here. just briefly as an introduction, looking at our health system, as of now, we have only 13 ventilators. Before the COVID, we have less than 5 of those ventilators. And of course, if you look at the WHO recommendation in terms of doctor to patient ratio, you can see that we are less than 2% of the total doctor actually needed, which actually means that we are talking about 0.25 doctor per 10,000. And of course, only quarter of the nurses needed are in the post currently in Sierra Leone. And this actually tells us that human resource, the medical practitioners, the nurses, those frontline workers will lack the adequate number to address our population in Sierra Leone. And then, next slide. Then, of course, which is also very much important, our out-of-pocket payment for health insurance, which means it's and donor health expenditure is 47%, NGO is 7%, and 1%, government is 8%. So this actually means that if the donor and NGO pull out of Sierra Leone today, our health system will collapse, definitely, because they are investing a lot of resources compared to government, which is 8%. So this is absolutely financing where we have, but as of 7th July, we have a total number of 1,572 active cases. 1,572. The active cases currently is 421, and then the number of deaths is 63. The recovery, we have over 1,800 recovery. So we are looking better in terms of COVID, although we want to matter over this. Okay. Next slide. Now, as of the 3rd of July, these are the resources that have come in towards the fight against the COVID. That came from different sources: government, in-house commercial banks, mobile companies, oil companies, private institutions, even individuals. And then, of course, we have the big guys, the World Bank and the IMF. For the World Bank, what they did here is they hire an audit firm to manage their resources. And that's one of the reasons why it's taking a long time for government to access that resources, because these audit firms have a whole lot of procedure, it requires a lot of documentation for government to request for those resources. And from the information I got this morning, government have not yet utilized most of that resources. That's what in fact as given as a grant to the response. For the IMF, it's a whole lot of a program, but which one of the main aim is to see how they can support government within this, how to support government in terms of the budget balance, in terms of how they can push in the goal. So they provide this $143 million. They are in the process of doing the transfer right now, the first 50% of that particular resources. So, so in terms of what is coming in physical cash, these are what we have now. So in total, we have like $163.4 million. That in terms of US dollar has come in so far to the government of Sierra Leone. This figure doesn't look at other resources that have come to the INGO. These are actually the one that came direct to the government of Sierra Leone. In other words, it goes to government processes. Next one. So, apart from the cash, we have a whole lot of donors that provide in-kind support, starting from UAE, China, USA, Jack Ma for Alibaba. So they help provide different types of medical supplies and aids, ambulances towards the fight against corona. So for them, they did not provide cash. They came with the equipment and the supplies and the medicines and provide to the government. So these are the major ones that actually provide in-kind support to the government of Sierra Leone to survive the corona. Next slide. Next slide, please. Okay. Slide. Yeah. Okay, then probably I will use my own slide. You know, apart from those resources that came in, the other question that people might want to ask is, where is this money going? For what type of support? For what type of support? So for Sierra Leone, you will see that for now, those in red, we are unable to get the details of how those resources were actually being utilized. For example, you see transfer to NACSA. NACSA is a government entity that provides safety net support to vulnerable groups. You can also see, like, for example, interest to the Minister of Health, which we don't have details yet in terms of how that was utilized. We also see like huge resources that is being transferred to the Emergency Option Center in EOC, like $8.9 million. We have not yet got the details of how that is being utilized. But for the one that we have gotten the detail, you can see that they procure 8 ventilators, 60 bikes for the military, 40 bikes for the police, and they purchased 50 vehicles and 100 motorbikes for the district operational command center. Interestingly, those 30 vehicles that are procured, they are brand new Toyota Prado vehicles. And what happened is, those vehicles were assigned to the district coordinators. And who are the district coordinators? The resident ministers. These resident ministers have official vehicle, but the government procure brand new vehicle again for the same set of people again that official vehicle. So you can see that in terms of priority, it shifts a little bit. And while at the same time, we have seen a lot of attempted strikes by the nurses and doctors that are the treatment center, isolation center, taking care of the COVID patients. In fact, the Doctor Association have issued a notice that by the 15th, if all of the allowances were not paid, definitely they will lay down their tools in terms of taking care of COVID patients. So it's one area we are very much concerned in terms of how is the COVID fund being skewed, for which particular area is that the real priorities. From our own context, we see that that is not a priority. The vehicle we are procured for the district coordinator, who happen to be the resident minister, and the resident minister have official vehicles. So now they now have like almost 2 official vehicles. So the priority have shifted. Instead of paying the nurses that are the frontline worker, providing more equipment, more supplies, so more resources now goes towards vehicles hiring and buying of motorbikes, purchases of brand new vehicles. Next. So now, just briefly, in terms of transparency and accountability in Sierra Leone, you know, and in May, the government introduced a constitutional instrument on the managing of COVID funds. And one of the things government did in that regulation, which was gazetted, they attempted to suspend the 2 key main accountability documents geared towards ensuring that people account for public resources. That is the National Public Procurement Act and the Public Financial Management Act. That was gazetted, but there are a whole lot of uprise from civil society, including some of our allies within the Member of Parliament. And we have to raise a whole lot of campaign, a whole lot of media campaign around that particular aspect. So thankfully, that constitutional instrument for now is not in operation, because the parliamentarian will engage, they vow that they will not table that particular document in parliament because it will reduce the trust in terms of the fight against corona. So on the IMF are part of that 1.3 million loan provided. We're happy that they were able to provide some accountability clauses there. For example, they say all large procurements should be published, and the names of the beneficiary ownership also will be published. This is stemmed from experience from the Ebola, wherein government officials will go and form a communing, and that communing will bid for government contracts, and they will get a contract. So we're happy with IMF on this particular one, that they should not publish all large public procurement, the contracts, including the beneficiary ownership of that particular contract. So we are hoping that they will start to do that one. As of now, they have not started that particular aspect. In fact, by 2 today, that's what I believe in, and I would like to leave early. By 2, I have a meeting with the head of IMF to discuss this particular issue in terms of what will happen if Sierra Leone fail to implement that clause, which was part of the condition for the credit to be given to Sierra Leone. Next. There are also a lot of internal accountability and transparency aspects on the fight of COVID. So we're now seeing government publishing regularly the aggregate, not the disaggregated one, aggregate income and expenditure in terms of what has come in and how have they utilized that resources. We're also seeing CSO demanding for transparency and accountability. The in-kind support, they've not been able to provide us details of those in-kind supports so that we're able to know whether they are adequate or they're not adequate. So if there might be any issue in terms of slippage or diverting it to other area, we might know if we know the detail of the information. But so far, we do not have the detail of this information. And if in terms of the funding, within our own structure, we have what we call pillars. Yeah, we have various pillars. We have communication pillar, security pillar, social relation pillar. So for now, we don't have the detail to actually show how much has been spent by pillar to these various areas. And we also see the Anti-Corruption Commission have launched the COVID-19 Transparency Task Force to ensure integrity, transparency in the use of management of COVID funds. Thank you.
Fantastic. Thank you so much. That was really, really interesting to hear about and really important to hear about the vital element of transparency and accountability in all of this. Thank you. So I'm very pleased to move on to our next panelist, Professor Adenike Grange. So Adenike worked in postgraduate tuition in various world-class medical institutions and became a professor of pediatrics in 1995 at the University of Lagos. She is the author of over 60 scientific publications in peer-reviewed journals. In 2004, she became the first sub-Saharan president of the International Pediatric Association. And then in 2007, she served as the first female Minister of Health in Nigeria. So she's gained recognition as a strong advocate for the health of children and women and the strengthening of health systems for universal healthcare. So over to you, Professor Adenike.
Okay, thank you, Tess. I'm happy to be here. Well, for me, it's morning. For you, it's the afternoon. And I want to thank my colleague, Elizabeth, Madam Lizzie, who introduced me to the Kampala project, to your group, and got you to invite me. Thank you for inviting me to give this brief paper. Thank you. My first slide is just to remind you of where Nigeria is. Thank you. Next. And the population, Nigeria is as you know, it is Africa's most populous country with a population of about 200 million, and it's the 8th most populous in the world. Its growth rate is 2.4%. Can I have the next slide, please? Just to run quickly through what our health outcomes are. All of them are not so great, as you can see. Can I have the next slide? But our gross national income per capita is just about over $5,000 per capita. Our expenditure per capita percent of our GDP on health is 118, and it's about 3.7% of total expenditure. Out-of-pocket expenditures over 70, it's about 70%. In contrast to what the former speaker said, actually the expenditure from outside is only about 7%. So what is happening? It means that, therefore, somehow the money is circulating within Nigeria, but the people are having to spend it, almost all of it, on living, on health, and food. So the important thing, therefore, is to strengthen the health system and improve conditions of service and strengthen infrastructures during COVID-19. Next, please. Just quickly to let you know how our health system has been structured. We've got the federal government, the state government, local government, and each level of government is supposed to be responsible for a level of care. On paper, it is quite good, but it doesn't always work because the local government is the least funded, but it has to take care of a lot more of the healthcare for the people, which is the primary healthcare. Can I have the next slide, please? Okay, well, how have we been handling the crisis in Nigeria? Usually, we target the areas of crisis. We have never had a pan-national crisis like this, where everybody is kind of hit and we all had to respond. So normally, we would establish, expand, and strengthen disease surveillance, outbreak prevention, disease control and response, and we will support life-saving activities and alleviate suffering through integrated and coordinated humanitarian response, focusing on the most vulnerable people, and we'll try to restore the health system in the states that are most affected. And so we have breathing space usually to move around states. But this time around, of course, all the states are kind of affected to the same magnitude. Next slide, please. So how prepared are we to cope financially? Not at all. As I said before, over 70% of the cost of health is paid out of pocket. But the National Health Insurance Scheme was started about 20 years ago. It has just started picking up in terms of trying to get the community involved. Mostly, the NHIS has been trying to cater for those in employment, in government employment, because the funds could be deducted from source. But the community-based health insurance scheme is actually the most important, but it's just taking off in a couple of states, and we think that this is where CSOs need to really pay a lot of attention. If we are to survive COVID and to strengthen our health system post-COVID, because it's supposed to target poor people in rural areas. Next slide, please. Next, those are the other forms of insurance. Next slide, please. Okay, what is health aid? Health aid is a voluntary action which is dependent on the recipient country from a donating country, governments, private organizations, individuals, which are for providing support and healthcare services of the recipient country. They include conditional and unconditional matching or non-matching, and open or closed-ended. Conditional aids list specific services on which the receiving government can spend the aid funds. Other conditions could include as well. An unconditional aid, on the other hand, places no restriction on the disbursement of the aid. But let me say that in looking through all the various types of aids that we have been receiving, most of them have actually, they are supposed to be unconditional, but quite frankly, there has been some there have been some conditions imposed, maybe in small letters, which come out later after we have got the aid. The conditional aids list specific services on which the receiving government can spend the aid funds. Other conditions could include various things as well. Next slide, please. Matching aid is not too common. Usually it is a matching, but in form of, sometimes there is a bit of matching in form of tax relief, which nobody actually takes note of, but it's really a form of matching. Open-ended aid places no limit whatsoever on the size of the transaction. The type of aid that is common, most common in Nigeria, is the open-ended. Can I have the next slide, please? Okay, right, we move on. But the most common one is actually the open-ended. And we have had so many of them, so many. The benefits and weaknesses of such health aids is that although the aid has sometimes failed, it has supported poverty reduction and growth in our country. But it is believed that there are so many weaknesses. The weaknesses are normally due to the way that the country itself handles the aids. And the previous speaker has highlighted the most important weakness, which is that most of the aid goes into the corruption cycle, which is rather unfortunate because then it further impoverishes the people who should be getting the aid. We've had several donors. Can I have the next slide, please? Next. Okay, most of our health problems, in fact, have been supported through health aids. HIV, AIDS, polio, myelitis, tuberculosis, maternal and child mortality, etc. And donors, so many donors have been involved, UNICEF, USAID, etc. And while I was in the ministry, my discovery was that, quite frankly, because there were so many people, so many countries willing to give aid to Nigeria for health, most of the money that was allocated to health by Nigeria was actually not being spent on what it should be spent on, because the aid that we were getting was becoming quite visible in terms of training of health workers, immunization, carrying out immunization, the various drugs that we needed were being supplied. And so all these were there, and that was really what the health workers were paying a lot of attention to. But the infrastructural strengthening was not happening, which to my mind was the greatest weakness of getting an aid that was open-ended and did not tell us and did not specify that we were to strengthen the infrastructure. Next slide, please. So most of our aid was targeted to the geographical areas where there were problems. They were targeted to certain services and products. They were targeted to certain populations, such as children, and targeted to specific diseases like polio. Well, in terms of polio, obviously this was a global thing. So we're all involved in that. And because of that, we are now free from polio, thank goodness. Next slide, please. Now, when we come to the COVID-19, one of the biggest problems that we had was the fact that we did not have a good infrastructure for passing on information to everybody in a coherent way and in in a uniform way, so that there would not be misinformation, and particularly with the advent of social media. So there was inadequate social response. There was no empathy or sensitivity in our messages. There was inadequate health response because we had not been used to dealing with our primary healthcare centers when there was any problem, any humanitarian emergencies. There was also inadequate labor response in that we locked down everybody and forgetting that most people needed to be out there earning their livelihood on a daily basis. And there was inadequate security response. And this, of course, gave rise to a lot of problems in many instances. Next slide, please. And there was still
Adenike, are you still there?
various isolation centers, and of course that was diverting the funds into just the COVID the COVID response, and they were it was not strengthening the healthcare system. There was also failure of moral leadership, which gave rise to loss of trust was failure of the people to adapt, loss of trust in governance, loss of control of security infrastructure. Next, please. Okay, we had a lot of response financially, internally, because by the time COVID came, of course, we had a good population with wealth in Nigeria. How they got the wealth, well, it was not very clear, but definitely they are very wealthy, and they started contributing so much that we actually lost control of knowing how much was being contributed. And many of the banks, that this is one of the things that is better developed in Nigeria, our banking system. We do have quite a lot of banks, which obviously is helping to roll over the money, the wealth of the few in Nigeria. So they all made huge contributions. And as the previous speaker has said, it was quite difficult to keep tab of this. So, you know, some of them we got a list of, but we didn't know how it was spent. There were supposed to be palliatives being sent to the people in states at the local government level, but there is a women's organization that carried out a study recently in 20 states, and they found that most of these palliatives were actually being hijacked by the officials who were supposed to be distributing the palliatives. They were able to record that. Well, it wasn't, I mean, we were not surprised, because this is something that had been happening even before COVID. So COVID just gave them another excuse to, you know, to hijack more of the resources that were meant for the poor people. I've put up this one because this shows that a huge sum of money did come in last month from Germany. But how have we decided to distribute this? Apparently, 8 million euro of 26 million would go to the UN World Food Programme in Nigeria. 7 million would go to the International Commission of the Red Cross in Nigeria, 5 million to the UN Food and Agriculture, and 3.5 to Caritas International. Now, these are structures, they are outside accountability framework. So it's quite impossible for us to follow up how to account for this money. Obviously, they would be accounting for it, but they would, of course, now give us, we would, now this is where the CSOs really need to work hard to follow on the spending pattern of governments when they get assistance, when they get humanitarian assistance. The last slide, please. Right. This last slide is just to let us know that there is a close link between health and the economy and sustainable national development. We all know this, but COVID has highlighted this for us, because without the economy working, we could not get our health to work, and without health, the economy would not work, and there would not be sustainable national development. So my advice is that CSOs need to do a lot more research, fact-finding, particularly at the grassroots and also at the governmental level, governance level, to follow, to track funding. Because really, what we are talking about is that although we may be able to get a lot of aid, the people who need this aid will not get any unless CSOs are able to help to get the aid to them. Thank you very much.
Fantastic. Thank you so much. There was a whole wealth of information in there for us. So thank you so much. I'm going to move quickly on now to our final speaker, who is Amanda Banda, who works at WEMOS and is a global health advocate in the East and Southern African region. So she focuses on the program's Human Resources for Health and Finance for Health. And Amanda is also the co-chair of the Health Workers for All Coalition, which is a global CSO network advocating for human resources for health issues. So over to you, Amanda.
Thank you so much, Tess, and also thanks a lot to the very enlightening information and presentations shared by the previous speakers. We can move to the next slide, please. So in my presentation, I'm just going to give a quick overview of trends in health aid pre-COVID, because I think it's important to understand where that leaves us during COVID, and if we kind of like seeing any patterns or similarities there. And in addition to that, then I will just go to the trends, then looking at the COVID response. Of course, this is still ongoing, and so we cannot really draw conclusions yet, but from the few things that we kind of like have analyzed, we are seeing some patterns, and then just a summary with like key takeaways. Next slide, please. So I think that Professor Adenike and the previous speaker as well touched a lot on a lot of things that I'm just going to give a quick overview here. So before COVID era, I think we saw, especially in the last 5 years, more of a disinterest in ODA in general, but more so also seeing a decline in the political interest in health generally. There was a lot of talks about the donor fatigue and health being seen as a soft sector and very inefficient. I think Dr. Adenike, you spoke to some of those things. And I think for a lot of donors, the question was, or the points, arguments is the low return on investment that the health sector and other social sectors are seen as. And so there has been, over the last 5 years, especially some cuts in health spending or donor money, and also more and more moving to strict eligibility criteria for countries, focusing especially on low-income countries with high disease burdens. You have mentioned also in the previous speaker's presentation the issue of hotspot specific populations and diseases, in fact, that donors are interested in, but also kind of like restrictions also alluded to in the previous speaker in terms of, okay, this is what you can spend this money on and this is what you cannot spend this money on. A typical example is that we have seen the reluctance of donors to spend on recurrent costs like health, HRH, human resources for health, in terms of paying for salaries and other investments. And we have also seen over the past years like a push for domestic resource mobilization, this rhetoric on shared responsibility and kind of like shared financing and responsibility. And more and more also the issue of efficiency has been quite prevalent. If you want to see more of the money that we're giving you, actually you can do more with less. And we don't need to be asking for more and more money, but we need to innovate and think, how can we do more for less? On the other hand, also in the donor countries, there has been also policy and issues that have impacted also the global health financing and ODA. And so the migration issue in the last few years has actually taken quite a huge chunk of the global donor agenda, and now we also see climate change. And for a lot of the global donor north-based countries, I think health security and securitization has been also like primary in terms of looking at health in the lens of security. And there were, of course, surprisingly, discussions and reflections around pandemic threats. And before COVID, I think the biggest threat was the antimicrobial resistance debate as well. And more also for donor countries, it has, for some context, I think you can argue, it has also been more of an economic interest in terms of, again, what do we get out of it, but also how do we use health also to expand our trade and aid and kind of like market expansion using health. And so one of the things that also has been alluded to in the previous speakers' points is also now more and more encouraging the move towards private investment in health, as well as insurances. We've seen also the pop-up of discussions around national health insurances in different contexts, and also having the private sector to provide services, and more also performance-based financing. And overall, we have now seen an emergency of a discourse around the effectiveness also of aid alignment and harmonization, and whether or not some of the global health partnerships and initiatives and financing institutions should be merged or not, and also the mandate that those specific global health financing institutions are actually to next slide. Next slide, please. So, slide actually is just, it's heavy. I think the slide will be shared, but I think it's just to show the trends in terms of the donor sources, in terms of where has the largest chunk of the resources in health in terms of aid have been happening, and also towards the program areas. So on the right side, you can see that HIV has been actually quite high in ODA and TB and malaria, and then followed by other diseases. But when you look at in terms of sources, you see that the US actually has been one of the biggest bilateral donors, followed by the UK, of course, Germany, and other countries. And then in terms of channels, you can see as well that there is different channels that aid has been flowing through, as also I think was perfectly demonstrated by the first year's presentation, where you gave us the breakdown of what channels have these resources. We can move to the next slide, please. So now looking at the current pandemic, the global and aid, it's actually quite interesting and difficult to find across the board information that speaks to just health. There is a lot, and I will share also information. There is a lot of information out there that is very much kind of like disaggregated and not kind of like speaking to each other. I guess it depends on who is doing it, and everybody's focusing on specific areas of interest. But this is from DevEx. I think this just came out early this week, if I'm not mistaken. They had an article, they ran an article that showed about $20.3 trillion that has been committed towards COVID response in general and across the board. This is global north-south, and it's not like disaggregated to take money or something like that. But what I found really interesting and striking is the health kind of like summary in terms of this is how much money is into health systems. Again, just to emphasize that this is a global figure. It's not aid money. It's what you can including the money that's into the COVID response in Europe, in the US, and in other rich countries as well. Next slide, please. So yeah, The closest that we came across in terms of information that has been analyzed that actually looks at donor trends and in health actually is done by the Gaza Family Foundation, and also the sites for more reading and more information. And this shows that at least by April, we don't have the list as yet, but we do have 19.3 billion for financial support for COVID. Of which, interestingly, of course, 85% was provided by donor governments, which the largest, again, being the US. So you can already start tying to the previous figures that I shared pre-COVID, like the source and organizations, and also, of course, the private sector is investing in yeah, so right that at most, and also with the help of the coalition, we kind of like did an overview, looking at, because we're also interested in resources for health. What we did was to look at all these flows of money that has been coming, or what was down to the COVID response. So we looked at Gavi's response in terms of what has been their response towards this, in terms of resources, but also what areas of investment priorities are focusing on. So, like IMF, GFF, and the EU. And so what we found, the Global Fund, of course, as far as now, they have invested at least $1 billion US dollars for the response. And Gavi, of course, is about 200,000, and other partners in that sense. So what we tried to look at was, where has there been any policy shifts in terms of the limitations around what their money can be used to invest in, generally in health systems or problematic areas. What we found was that there is countries that will receive this money can use, but pretty much already focusing on vaccines, the PPE program, kind of like response in terms of actual service delivery, and also diagnostics. And of course, there's a lot of money also going to research and development. And we now take and kind of like look specifically for human resources for health to see if there's any specific policies that these donors have around HRH. Only Global Fund has a specific like guidelines and a policy document around this is how the Global Fund will invest and spend money in HRH. And we found that they were very consistent in terms of, as much as we don't want to promote us as donors financing HRH, we don't want to encourage that, but we will kind of like, of course, allow countries to recruit human resources for health with our resources. For Gavi, there was no indication at all in terms of HRH, except for training healthcare workers for response. And more or less, didn't pick anything up on the DFF side. Also on the EU, of course, although I know that at least sometimes they did announce some funds or some partnership with WHO that entails some elements of health, but when we have inquired, it's not quite yet specific in terms of what and how that money is going to be spent on. I think for World Bank and IMF, the issues were, will they change their positioning around restricting wage bill and advising governments on the wage bill restrictions in terms of how much they can recruit workers with public funds, which is why we having shortages in terms of countries to look at because they cannot go on certain wage bill restrictions according to the and IMF's recommendations. So we have not seen much of a change yet, although we have to, of course, engage with some of these major donors, specifically on HRH. The GFF has given us indication that they might put a time limited conditional clause in the new strategy that they're developing in terms of maybe let's allow a bit of money to go into health system strengthening, especially like HRH, but that is not quite yet definitive yet in terms of this is possible. But basically, this exercise, I think, is showing us that there hasn't been much changes in terms of the direction and how the donor trends or what is driving the issues. And I think that my previous speakers, the previous speakers, did give practical examples of how that is also clear. And so on the global level, on the global level, we see the same issues, the lack of accountability, the lack of also the donor harmonization and alignment, and questions around sustainability and reluctance to invest, because I think those also not understand big budget lines and investment lines where governments are not showing promise to take over and continue the investment. Next slide, please. So yeah, in terms of key takeaways, of course, this is that we made, and I think a few more are still being made. It's still work in progress. We don't know how the future plays out. And like I said, we have not found, like, there is a gap actually in terms of analysis and information. And I think previously also mentioned this, that there is need to be invested to really dig in terms of how is this really playing out, what is changing, especially with COVID. So the disbursements, I think at least for Sierra Leone and Nigeria, you've actually showed us how that money has trickled into country, how that is being spent, and the accountability issues, I think, are both issues at the national level, but also at the global level. For example, with World Bank, as we followed the conversations on human resources for health, we also reached out to ask for clarification around how are you selecting the countries that will benefit. Like, there's a lot of like lack of information, and I also like accountability in terms of how some of the decisions are being made. For the EU investment as well, we heard it's 10 countries in Africa. We don't know which countries yet, how they're being decided also, we don't know. So similar things that I guess also colleagues at country level are facing. And yeah, it's also both loans and grants, and this is also something that is worrying. And there's again more and more push for we need to innovate in terms of how we are financing health. And I've mentioned the investments in private sector and really the privatization of health aid as also a big problem in terms of this is actually being encouraged now. And one of the key takeaways I think that we need to reflect and think about is also the question on government's ability to actually invest in their own health, given also the high debt burden and the economic impact that COVID will have on countries. Do we see that this is still something viable and feasible, and what next? I think there's need to have conversations around rethinking domestic resource mobilization and the whole health aid discussions in terms of how this will be taken and moved forward as a matter of urgency. And yeah, I just repeat that we see the same trends actually pre-COVID as now. Nothing is really changing as yet. And still, even in COVID aid that has come through, you still see the same reluctances and conditionalities in terms of this is what we can spend on and this is what we cannot spend on. But I think most of us agree that there's need to really focus on investing in the infrastructure in health sector and the health systems itself, than specific peaks and pockets of investments as the donors prioritize and please. So we can move to the next slide, which I believe is the last slide. So yeah, like I said, the lack of coherence or cohesive information and analysis around specific details, especially for health alone, in terms of how the donor aid is flowing. I think there's quite a lot that is being done. As you can see, I've listed a lot of resources here from DevEx, from Eurodad, Kaiser Family Foundation, we are also doing something, and also recently Donor Tracker is also working on something, but they are not all specifically focusing on health, and there's quite a lot of mix of issues overall to do with the resources that are being pumped in the COVID response. And so that's also just to emphasize the need for us as civil society organizations to follow through, as my previous also speaker highlighted, that maybe the need for more research and digging into the data to really pick what is really coming out of this and what should we be worried about. So I will stop there. Thank you so much for the time.
Thank you so much, Amanda. Great, I'm just going to pass over to Clemmy now.
Great, we thank you so much, everybody. We thought it would be just possibly appropriate just to have a little shake. We've all been probably sitting down for a while now, so I'd just like to invite you to stand up, shake out some of the energy, move around, do what you need to do, stamp your feet, just so that we can revive after sitting down for such a while, because we're about to invite you to share some thoughts, possibly sort of inspired from what we've just heard, but very much about your own experiences. So if we could get the next slide, please. So using the chat, could you answer our question? So from your own experiences, what are the challenges you have witnessed with health aid response to COVID-19? So we'll just take a few moments to pause and to think about this. So personally, from your own experience, what are the challenges you have witnessed with the health aid response to COVID-19? So we will be collecting these responses from the chat and turning them into a Google document that we will be sharing and using for our second webinar next week. So I'll just read it out once again. So from your own experiences, what are the challenges you have witnessed with the health aid response to COVID-19? Great, we're getting lots of responses, thank you. Thank you for participating. So I'm just going to invite, if anybody would like to reflect on some of these comments, if you'd like to just raise your hand, and we will invite you to speak personally about your own experience. Yep, looks like we've got somebody, a couple of people.
Thomas, were you able to move those speakers to panelists?
I did already with Busy Bright, so she's there.
Fantastic. So busy.
And Akan would also be there.
Fantastic. Busy, would you like to come in first? If you want to unmute yourself, you should be able to speak now.
Yes. Hello. Thank you very much. Hello, everyone. It's a privilege to be here. I'm Busy Bright, CEO of Live Well Initiative, LWI Nigeria. Now with Nigeria, I'm really proud of our former Minister of Health, Professor Grange, who gave us a presentation earlier on today. I just want to confirm that from the private sector healthcare in Nigeria, we found that the first response we experienced as a nation was that the general corporate private sector got themselves together, formed a coalition, which they named as the CACOVID. And CACOVID is a short synonym for Coalition for COVID in Nigeria. Now the CACOVID jumped into action. They set up in partnership with government COVID isolation centers, which they built and equipped. They also went into helping government to procure some of the reagents they needed for the gene experts and this and that, things that they needed for the molecular laboratories. Of course, government was the one constructing the laboratories, but the private sector helped in boosting the number of tests per week. And they also helped in providing foodstuff for the furloughed workers as well as the lower income Nigerians. And so we found trucks and trucks of food products being distributed nationwide by the Coalition for COVID. So in that sense, I would say that the private sector in Nigeria rose very quickly to the occasion, and they were partnered with by the Healthcare Federation of Nigeria, which is the private health sector coalition in Nigeria. So that's all I'll say for now. Thank you.
Thank you so much. So our other Akani Obot, would you like to speak? If you'd like to unmute yourself. Thank you.
Hello, everybody.
Hello.
Yeah, good afternoon, everybody. Where I am is noisy, so I'll just be as fast as possible. Now, from what we've witnessed about the COVID-19 response from our own government access or aspect is that the National Procurement Act was not adhered to by the government. After getting on the fund for combating the pandemic, government was supposed to follow the National Procurement Act, of which there is a space for CSOs to come in when it comes to the National Procurement Act. CSOs have a part to play. But government, because of the insincerity in Africa, like Sierra Leone that Abu spoke, and Nigeria station that Professor spoke, we saw that government, they are not sincere. Now, the second aspect is that the Freedom of Information Act also in Nigeria was not adhered to. Up to now, we do not know how much has come in to combat COVID-19 in Nigeria. It's a big situation. When we are talking like this, we all have agreed that CSOs have a part to play. Even when we had a meeting today, African Union, still on this combating of COVID-19, we agree that CSOs have a part to play. How do CSOs now play the part when they don't even have knowledge of the fund money that's coming and where this money are going into, because it was not projected to? How do we track the money? How do we hold government accountable for the money or for the monies that have come in so far? So it's really a big problem. And one of the narratives I want us to really change is the aspect that a donor that comes into a country should be able to tell government as a matter of policy that CSO should be actively involved in every program that they want to carry out in every state. It's not to just carry the money and come and dump on the lap of the government. Or we should know that our government up to now are not sincere, and that the money will be diverted to some other things, like what we've seen in this COVID-19, of which up to now, I'm still afraid of the health system in Africa after even the COVID-19. it will still be the same thing the way it was before COVID-19. Thank you, everybody.
Thank you. Thank you. I'm afraid that's all we have time for in terms of speakers to this question, only because we'd like to invite you to answer one more question before the end of the webinar. For those who did have something else to say, I hope you've managed to say it in the chat. So our second question follows on. What have these challenges exposed about global health aid structures? What have these challenges that we've just identified exposed about global health aid structures? If once again you could use the chat to answer this question, we will be using these questions to form the content for our second webinar. Thank you so much for participating in this question.
Thank you, everyone. This is fantastic. Great. So unfortunately, we've run out of time, which is such a shame because it was great to start hearing all of these ideas. But the idea is in the next webinar, we're going to bring these all together and start to think around what do the solutions look like, or how do we shift these issues, these challenges that we've highlighted in this group. So if we could just pop to the next, I think we skip the next slide and go to the one after that. And then the one after that as well. So I just wanted to very quickly cover next steps before I pass back to Ravi. But so as we said, we've got the second webinar next week, which is at the same time next Thursday, the 16th of July. And it would be fantastic to see all of you there so we can continue this conversation. As Clemmie said, we're going to be putting these ideas and these thoughts and these experiences into a document, which we'll be sharing with you all that we can all reflect on and add to and keep shaping as time passes and refer to in our work. So we'll hopefully send that out to you with the slides and the recording tomorrow. And also, as I mentioned at the start, we're hoping this can be a continued conversation in some shape or form. So if you're interested in continuing this conversation in any way, please feel free to reach out to either myself or Clemmie. And finally, just to say thank you to our fantastic panelists. Thank you to all of you for attending and contributing and participating in these conversations. And thank you to the Kampala Initiative for hosting this great session. And I'll pass back over to Ravi now.
All right, thank you, Tess. We'll wrap up now. It's been a very rich discussion. I think we've heard a lot from these 3 different cases that have come forward in the presentations. And a lot of information really coming up very strongly on the chat box. As Tess said, this is just the start of the discussion. We have a follow-on second part in the series. That'll be same time next week. So look forward to seeing you there. For those who are interested, there's more information about the Kampala Initiative in the link on the chat box right now. We encourage you to sign on if you've not already done so. Take a look, see if you are willing, and if you agree, you can endorse the Kampala Declaration, and that will get you enlisted into the Google Group email chat. And you can learn more about future webinars as they come up. So with that, I'd like to thank once again, as Tess has done, our three presenters. Fantastic job, really, really rich and interesting cases. Encourage all of the participants to come back next week, and let's have a follow-on conversation. I think, Tess, just a quick thing to hear from you or Clemmy is about the next steps in terms of a Google document. I do believe that there'll be something that comes up, and I think it's just good to reiterate that.
Yes, of course. Yes. So we'll be creating that today, and hopefully we'll be able to get that to all of you tomorrow for continued reflection and adding to.
All right. So another reason to get back into the Beyond Aid email group by endorsing the Kampala Declaration. Those who've done so already, no need to take any further action. And with that, I think we have wrapped up. I don't want to take up much more time, but thank you all for your active participation, and we'll look forward to seeing you next week.
Thank you.
Thanks, everybody.
Thank you.
Bye.
Cheers then. Bye-bye.
Bye.